me. All right, so hello everybody. Thank you so much for your time today. My name's Brenna and I'm a social worker at Baystate High Street Adult Medicine. And today I'm just going to go through a little bit of information about depression in older adults. So we'll talk about screening, diagnosis, and treatment, and I'll also provide some information about the social work perspective on depression and on social determinants of health. So if you could, the first question is just kind of why depression? Why treat depression? So right now, 1 in every 10 older adults receiving care in a primary care setting meets the criteria for depression diagnosis, and we'll talk more about why that is as we go on. And it's also, a lot of times people think of depression as immovable or as a life-changing diagnosis, but it really is very, very treatable, and there's quite a few different approaches that can be very effective. One of the reasons why we treat depression is to reduce healthcare costs. We can be upfront about that, but then the other one is just to really increase quality of life. Depression diagnosis is highly associated with medical excuse me, you can read the word, I apparently cannot today. And depression occurs for a lot of different reasons. It's neurological in origin as well as psychological and cultural. So here we've got some risk factors for depression, and as you can see, I've broken them out into 3 different categories: physical health risk factors, mental health risk factors, which you would really have a lot to do with somebody's history and current substance use, and then social determinant of health risk factors. And I just want to focus on those for a moment. We talk about depression, but depression is really associated with oppression as well. And when you're looking at social determinant of health risk factors, those are the areas where a classic social services intervention may help reduce depression before any other interventions like therapy or psychopharmacology are even tried, because those social determinant of health risk factors are strongly associated with the environment that the person is living in. And the way that living in that environment may make them feel. So somebody who is on oxygen, who can't access a shelter due to being on oxygen and is about to lose housing and is thinking that they may have to sleep outdoors, is of course going to present as somebody who's very depressed, very anxious, and very fearful. But that anxiety and that depression may be so situational that helping them to find a resolution to their housing may also resolve those symptoms. It's okay, you can move forward, thank you. So the symptoms of depression in the general population are the ones that I think people are most familiar with depressed mood, disturbances to sleep or appetite, fatigue and lack of energy. In older adults, it can emerge in some different ways as well. So a lot of times that looks like unexplained physical complaints, headaches, memory loss, nausea and diarrhea, and agitation. And then older adults are also less likely to describe their mood as depressed. This is partly cultural and generational. And then it's also important to note that in the United States, we really talk about depression as an internal disruption to state, whereas other cultures often express depression as a disruption to intrapersonal symptoms or interpersonal systems. So, they may be describing difficulty getting along with other people, social isolation, pulling away from important communities, or finding that they don't feel as connected to the people that care for them. And those are all symptoms of depression as well. Okay, I'm ready to move on. So now we'll just take a quick look at some of the screening tools. The PHQ-2 is just, as you can see, a very, very brief measure. The PHQ-2 lets you know whether you should move on and continue to screen with the PHQ-9 or with the GDS. So then we'll take a look at the PHQ-9, which I think probably everybody is familiar with. This is the standard depression questionnaire that's used in the clinic here at High Street. And it asks people to rate their depression from 0 to 3, essentially from something that never occurs to something that occurs all the time. And I just want to highlight that the specificity is 88% and the sensitivity is also 88%. And that's globally, not specifically for older adults. And now moving on to the GDS. The GDS is more effective for older adults who may have a disruption to cognitive function or who may have a dementia diagnosis or who may just feel really overwhelmed in the visit. And this has a higher sensitivity and a higher, slightly lower specificity, but a higher sensitivity. And the reason that this particular screener is more effective for older adults is because it asks yes or no questions. The content is really the same, asking about anhedonia, asking about isolation, asking about hopelessness. But instead of asking somebody to look back over a period of weeks, it's really asking how are they in that moment. Okay. We can go to the next one. So there's several evidence-based practices for depression. It's really important for older adults that those practices are available in the same place from a team of providers that they trust. Older adults are less likely to seek mental health care. They're more likely to associate some of the negative stigmas around mental health with their experience of depression. So having a provider team that can address depression as part of their whole person care really helps them to be more consistent and more accepting of services. And then down at the bottom, you can see that there's, psychopharmacological interventions, there's community interventions, and then there's also therapeutic interventions. And so what it looks like when someone is referred for therapy is that there's an initial assessment with a psychosocial history, then goals and a plan that are person-driven, and then work on skills building, reassessment, and then planning for termination. And I think the difference between a psychiatric approach and a social work approach is often that psychiatry really focuses on reducing symptoms and this idea that you kind of move backwards from reducing the symptoms to curing or making whole the syndrome that led to the symptoms, whereas social work takes an approach of building skills to manage symptoms. And so in therapy, we really look a lot at adaptive coping versus maladaptive coping, and those coping skills have generally been shown to be more or as effective as other interventions. And so adaptive coping skills that we would focus on are building instrumental support. So building that team of care providers around a person who help them to feel connected and who help them to have any missing social determinant of health needs met, involving them in planning and returning somebody's sense of agency and sense of being able to be a good decision maker in their own life, building acceptance of any changing health diagnoses, reviewing emotional support, and then helping somebody to positively reframe or look for strengths in the circumstances that they're experiencing, and helping them to connect with their spiritual and religious needs. Maladaptive coping that we would help people kind of recognize and move on from includes behavioral disengagement, denial of any health or mental health needs, self-distraction, so that can show up like drugs or alcohol. It can show up in moving away from connectedness to tasks and hobbies that are really isolative, like somebody tells you, I used to go to Mahjong twice a week, and now I just watch movies all day long. Self-blame and venting. So those are all domains we can work on in therapy. And again, there's a lot of really great resources for helping people to connect to community. And I'm always available to talk about any interventions for depression, to help people get connected with community resources, to help people explore resources for support, because sometimes people are just more comfortable doing, faith-based counseling or going to a day program or talking with a trusted family member. And I'm also available whenever there's any questions about depression, and I'm happy to be part of the team and happy to help, and appreciate your time today.
Thank you, Brenna. I think that's a comprehensive summarize of how do we know about depression in older adult. I really like when you highlight that the social determinant of health, which is not commonly addressed for our older adults. There's some question about who can screen. I think with the screening tools, I think our MAs can screen that. So our nurses can do that screen as well. Now, the specific question about the role of treatment for individuals with dementia. So I think it all depends on what the level of dementia that individual is. So certainly, if the patient can participate and able to know, able to express their feeling of depression, I think talk therapy would be beneficial. In terms of medication, again, it depends on where the patient is. If the shared decision making is to start somebody on medication, then it's okay to try, but follow up with if the effect of the medications. So on the next few minutes, what I'm going to talk about is the pharmacology treatment. So DSM-5 is actually a mirror of PHQ-9. So if you have 5 or more symptoms over the 2 weeks, and then you probably met the criteria for depression. So for medications, the common medication that we use in the group of SSRIs, selective serotonin reuptake inhibitors. So the common one that we use are escitalopram, which is also known as Celexa, escitalopram or Lexapro, or sertraline is commonly that we use. We try to avoid the older SSRIs such as Prozac or fluoxetine because of potential side effect and interaction with other medications. Then you have another group of SNRIs, duloxetine or Cymbalta, that we try to use if somebody has some sort of chronic pain and some mood disorder, so that may be something to consider. And also venlafaxine or Effexor that you could use, but the potential side effect is hypertension. And also you have to really consider reducing the dose with anybody with chronic kidney disease. So we actually have a case that somebody came in with visual hallucination because they went into renal failure and they have visual hallucination from venlafaxine, higher dose of venlafaxine. So other antidepressant to consider will be bupropion or Wellbutrin, but you have to be cautious when somebody has seizure disorder, so probably not my first choice with underlying seizure disorder. We tend to use a lot of mirtazapine. Mirtazapine, we use the side effect of sedation at night at low dose or potential appetite stimulant that we at low dose of 7.5 or 15, but as you go higher, then you lose the effect of the stimulant and sedation. Other therapy, as Brenna says, psychotherapy. So the recommendation is combination of psychotherapy and medication. So you do it for a few months and you don't see an effect. So recommendation is to switch to another medication. So if somebody's on Zoloft or sertraline and that doesn't work, then you can try to switch to citalopram of the same group. Or you can also decide to switch to another class from SSRI to SNRI in another group. There are some study that shows that if you use combination of two antidepressants, that may be helpful, but it's not FDA approved. But if I'm reaching that state, then I probably would refer to our psychiatry colleague. And then there are in certain cases that that you may consider medications such as lithium. Antipsychotic, you probably see in the on TV advertisement these days, like if your depression is not controlled, you talk to doctor about this. Eproprazole is another antipsychotic that in combination of SSRI that may shown to be helpful. And in severe depression, that somebody is psychomotor retardation, that they are not eating and drinking, they're totally stiff, then ECT may be an option. So once you start, how long should you continue on? So if this is the first episode, then you may continue for if this is their first episode, you may know further symptoms, you may consider tapering down. But otherwise, it's depending on the patient condition. So I think just to summarize is depression is quite common in older adults and frequently underdiagnosed and undertreated. I think just to be aware that our elders has atypical presentation. As we talk about Diego, is he doesn't go to church anymore, and why is that? And combination therapy is possible, but I think as provider, as we're waiting for referral to see our psychiatry, is we can start the treatment first.